drugs affecting bones and joints. So we're going to go through gout, anti-gout agents, medications for osteoporosis, and then a few analgesics and things like that. So let's jump right into anti-gout and uricosic agents. So gout, it's just not a bone and joint issue. It also has increased hypertension and cardiovascular risk associated with higher uric acid levels. So you can use the DASH diet to help with heart disease, but it also helps with gout. So it's one thing you want to recommend to your patients who have gout, not just a current gout attack, but also for the prevention of gout attacks in the future. And you're going to want to increase their fluid intake because most people we know don't drink enough water, so they're going to need more fluid to flush out those crystals that are the crystallization in the joints. So, xanthine oxidase uses on patients with gout to prevent inflammation, prevent the synthesis of uric acid, which crystallizes in the joints and causes that pain. The two options you have are allopurinol and febuxostat, or brand name Uloric. The aim of these is to decrease the serum uric acid levels to less than 6 milligrams per deciliter. It does not discount the need for anti-inflammatory agents, especially when patients who have an acute gout attack. So think of these like in COPD. You need a rescue inhaler along with your allopurinol that's acting as your maintenance medication. So it doesn't actually treat an attack, but you start it during an attack for once the attack's over, prevent another one from happening. You also have colchicine, which does not impact purine metabolism. It has anti-inflammatory properties, pain medication. It helps with pain, and it can be used prophylactically or during an acute attack. Usually it's used, a lot of times we'll see it used during an attack, and there's a set regimen you can give it with. It used to be, 15 years ago, they used colchicine. You basically said take one every hour until diarrhea happens, and that's how you knew how much you could have during an attack, because that is going to happen for patients who are on this for an acute gout attack. It is going to cause diarrhea. There's no way about it. It's not even an adverse effect. It's kind of what we're going for. But now, it has to be 10 to 15 years ago, colchicine went through FDA approval. Interestingly enough, colchicine was actually being used before the FDA was formed, so it was grandfathered in under the FDA without any true dosing regimen or anything like that. So, long story short, a company did the trials to get colchicine to full FDA approval. They were given brand name rights for a couple years. The price skyrocketed. Lots of people missed out on a medication that they could no longer afford and desperately needed, and lots of money grubbing ensued, and the FDA got theirs, and luckily we're finally back to having a generic colchicine that people need for their attacks. But there's a set regimen you can do, a dosing regimen now that for use. You also have a few other options that can impact uric acid excretion or change it to an inert substance. They're not used for monotherapy. Medications, they're not used in pregnancy except for probenecid. So there you've got its little niche. Not used in children. Uric acids when mobilized, uric acid crystals when mobilized can precipitate renal stones or kidney stones. So be careful in patients who also have kidney stones who develop gout. GI disturbances are all over. It's just common. You're going to see it more with colchicine than any of the other ones. But allopurinol, fairly benign medication, given once a day, but can cause a few GI upset until they're getting used to the medication. So start them out on 100 milligrams daily, and then bump them up to 300 as they tolerate. Allopurinol can cause hypersensitivity rash higher incidence in African Americans and Hispanic patients, but is not a contraindication. It's just something to watch for. And colchicine can result in myopathy, weakness, and malabsorption of B12. Malabsorption of B12, we're going to talk about it later, but keep it in mind that also can present, it can present as peripheral neuropathy. That's what most people see it as. And there's actually some diabetic medications that can cause that also, the main one being metformin. So that when we talk about diabetes, we'll talk about how that can kind of, it can actually affect the dosing we're doing, thinking that the diabetes is causing peripheral neuropathy, when actually it's the medicine, and we just need to give some B12 supplementation. Here's what to consider when giving it to older adults, and you have some off-label uses of colchicine. So that's all we're going to talk about for gout medications. There's not that many of them. What you're going to see now, really used now, unless it's special populations, you're going to see colchicine or indomethacin, an NSAID, used for or steroids for an acute attack. And then you're going to start someone on a preventative medication, most likely allopurinol. Other options are Uloric or the febuxostat or daily colchicine. And then you're gonna put them on a temporary one like a temporary short-term medication when you do start them on maintenance. That way you don't, because you have a chance to precipitate a gout attack in the beginning. And there's algorithms you can look at that are available all over, but they're very simple. And those are really your five main drugs that you're going to see now, unless it's a special population: indomethacin, colchicine, oral steroids for acute attacks, and then allopurinol or febuxostat and colchicine also for maintenance. So arthritis medications. Osteoarthritis is going to be a common complaint, especially for your older patients, patients who've worked a lot with their hands. Even now we're seeing patients who are typing a lot. It's just loss of cartilage in between the bones. You end up having bone-on-bone grinding, which causes pain. A good thing about osteoarthritis is that the more you using the joint will actually lessen the pain. That's why a lot of people, their bones are stiff in the morning, and they can work their hands and move them, and eventually kind of get through a lot of that stiffness and pain. But you're also going to probably need to give them some kind of medication continuously, something scheduled to try to prevent it. So most likely it's going to be acetaminophen or an NSAID. So acetaminophen is the first line for osteoarthritis. It's good for the pain that they have with it, and then given up to 4 times a day, it's good for preventing the pain that they'll have. Obviously, hepatic concerns come with Tylenol or acetaminophen, especially when they're getting multiple medications that can possibly contain Tylenol, because you've got to think that there are you may have a prescription pain medication like Lortab or Vicodin or Percocet that's got acetaminophen in it. If they get a cold product over the counter, it's most likely got acetaminophen. There's some allergy medications. Acetaminophen's in a lot of different things. So you want to make sure that you watch for that. You're more so concerned with the overall number of grams of acetaminophen gotten in a day than, if you're going to give them Tylenol for osteoarthritis, you're not worried just then there's going to be hepatic concerns if they're not on any other medication. You can even give acetaminophen in people who have hepatic dysfunction as long as you keep it under 2 grams, 2 grams a day. I've had that conversation a lot, and you have to pull up that reference a lot. Up to Date has a great article on osteoarthritis in hepatic disorder, because we don't have a great option, but there's a lot that can be used as long as they're kept within certain parameters. NSAIDs, we're going to keep to the lowest dose possible. There are concerns for increased cardiovascular, lipid, and hypertensive conditions, because think about it this way: NSAIDs cause sodium retention. Sodium retention causes water retention. So increase in sodium and water retention is going to lead to hypertension and possibly cardiovascular events. So that's where they're linked. NSAIDs, sodium, water, both sodium and water, cardiovascular events and hypertension. Topical NSAIDs like Voltaren, which is diclofenac 1%, safer than oral therapy and has a benefit. We use a lot of Voltaren because we have patients on lithium, and the NSAID lithium interaction can be severe. Interactions can be severe, so we use a lot of Voltaren, but Voltaren has to be given in certain dosing regimens. You can't say apply to affected area 4 times a day. It is either 2 grams or 4 grams using the measuring card in the box, depending on what joint it's in. It's also not only approved for knee and hip osteoarthritis. It's not FDA approved for the hands. So an insurance company may not pay for it if you're using it for your hands or shoulder, ankle, any other joint that may have arthritis in it. You can still use it. It's fairly inexpensive. One box of 100 grams is about probably about $30 at this point. So the patient may be able to afford it, but you have to write it as especially for insurance to pay for it, you have to put it as 2 grams or 4 grams for each joint, per joint, with a maximum of 16 grams per overall for the whole body. You can't do more than that. Glucosamine therapy is good for patients, especially if they want to try something over the counter. It may help, it may not. Some people, the evidence is back and forth out there, but it's not going to hurt them. So you can give glucosamine. You want to give it with something with chondroitin in it. So they'll have combinations, bone and joint, glucosamine, chondroitin, and that's basically precursors of cartilage formation. You're taking them in to hopefully kind of replenish the cartilage in the joints. The only downside is you have to take it several times a day, but other than that, it's very inexpensive, very easy to get over the counter. Steroid injections are used when need for physical therapy, oral medications, for weight loss, and overall gradual activity increases. If you need those things, injections into joints bring the risk of infection, and are typically limited for infections per year. You also have hyaluron injections, which can be given, and you can even give them at the same time as the steroid injections. The only limiting factor in that is going to be the cost of them. But in general, steroids take several weeks to take effect, and if you're giving them 4 times a year, so that means you're giving them over a 3-month period, they're going to be effective really like week 6 to week 12 of that 12-week period. The hyaluronic acid, the non-steroid injections are going to be real effective at the beginning, but they're going to fade fairly quickly after about week 6. So, there may be a benefit in doing both in a patient. All right, and again, steroids. Look on Canvas. There should be some guidelines posted up there. It's fairly straightforward with algorithms and what to try next. It's basically just try this medication. If it fails to control pain or discomfort, move to the next one. So there's not a whole lot of guesswork in it, which is really good. Rheumatoid arthritis is an autoimmune destruction of the joint itself. They have high inflammatory process, the joint swelling and erythema of the overlying skin. There's bone loss that can contribute to disability and heightened immune response. So here we're really working to prevent subsequent RA attacks so that we don't have bone loss later and lead to disability. It is a systemic issue. You can read through there talking about other organ systems that are involved. They're going to coordinate with a specialist to treat this. A lot of times patients are going to be put on disease-modifying anti-rheumatic agent or drugs called DMARDs. Smoking increases the risk and progression, so keep that in mind. and contraceptive use for longer than 7 years can be protective, quote, for a few years. So steroids are no longer for primary or long-term use. The goal of RA is to keep steroid use under as low as possible. So what you're going to see is DMARDs or methotrexate. So methotrexate is an early choice. Takes about 6 weeks for full effect. Can be mixed with other DMARDs, and it is a pregnancy category X medication. So one thing to keep in mind with methotrexate is it is not a clean medication. It's got drug interactions, side effects, pregnancy category X, but it's a very effective medication. So there are things you have to take into account, but it's very good at what it does. And it's not as expensive as the other options, so this is a first-line option for RA. It does have GI distress, folic acid deficiency, photodermatitis. It can be hard on the kidneys, liver, and platelets, so you have to monitor it. And it's also a chemo medication, so you want to wash urine-contaminated clothes separately. Hydroxychloroquine or Plaquenil. Everybody's probably heard of this one because last summer you couldn't get your hands on it because people were trying to use it for COVID-infected patients. But it is another option for patients. You do have to, one thing I want to note, you have to it requires yearly eye examinations because it can have significant corneal deposits and retinal degeneration. So as soon as that develops, you have to switch them to something else. You can use minocycline, which is in the tetracycline class of medications. JAK inhibitors. These are the Xeljanz. These are fairly new. You see commercials for them on TV. It can be in combination. It's oral over injectable. So that's why some patients will like it, and it helps with bone erosion, but it does increase the risk of infection. Then biologics are going to be your TNF alpha inhibitors and non-TNF alpha inhibitors, and you can see most of these end in CEPT or MAB, and those MABs are the monoclonal antibodies. They're all going to be infusions, once a week, once a month, once every 3 months. There's a schedule that they'll have to be referred to an infusion center to get. I know that there's one in Greenville, there's Spartanburg, Anderson. Around here, they're not as common as like a normal pharmacy, but they can get in and get on a schedule to get these, and most of them are, I think, fairly quickly. 30 minutes and they're done. So it could even be kind of done on their lunch break, maybe, so that they don't have to take a lot of time off to take care of them. But these are going to be after you've done your methotrexate and your hydroxychloroquine. You're going to jump into these biologicals and non-biologicals like your JAK inhibitors. So all of these are kind of in that same level if they've failed the first two therapies. They have strong immunosuppressive properties. They can only be prescribed by a specialist, and many are subcutaneous injections. So you're either going to get an infusion or an injection, kind of like like an insulin pen. So some concerns: you can't receive any active or live agent vaccinations. There's an some about increased risk of cardiovascular and vascular diseases, but still not worth not getting when you consider the long-term effects of RA. And post-infusion reactions can be severe, which is why all the infusion centers, they have nurses and physicians available monitoring the patients with protocols set up just in case something like this does happen. You're going to hear a lot about biosimilars, which are coming on the market. These drugs, they're not generic versions of what's out there, but they have the same clinical endpoint as them, and it's not something that I've used a whole lot of because we don't use a whole lot of infusions and monoclonal antibodies, but it is increasing access to the monoclonal antibodies with helping at least control the cost of them. So you're going to hear a lot more about these coming up. So just be familiar with the name biosimilar, knowing that it's another type of monoclonal antibody to give people access to. they can only be used for the same FDA approved indications. So if you've got, so it has to be for, if it's approved for RA, it has to be for RA. It can't be used for all the other things the drug's used for, off label. So they can be substituted. Cost savings at this point are not significant, but they're growing. They have the same risk that the original has. So we're going to skip these. You can read through these. Calcium and vitamin D, osteoporosis is something most people are familiar with, where the bone is, the cells that build bone are not keeping up with the cells that break down bone, and so you're at an increased risk of hip fractures, bone fractures. Calcium and vitamin D together prevent and treat osteoporosis. It does not have to be a tablet that contains both of them together. You can buy calcium and vitamin D, but you need to take both to prevent it. You're going to take calcium and vitamin D. You're going to do low impact bone strengthening exercises, small weights, things like that, which have been proven to be very beneficial. And then you're going to take a medication based on your DEXA scans and your FRAX scores. So, estrogen. Most people who develop osteoporosis are female. Estrogen can be used as an option. When you get into estrogen, and you'll talk more about this when you go over hormone replacement and things like that later on. Estrogen can only be given by itself if somebody has already had if they don't have a uterus, if they've already had the surgery to remove it, or else you have to give it with a progesterone to decrease the risk of cancer. Obviously, there's side effects that can come with it, so it's not something you would give to everybody. It's not our first line option. It would only be for patients who are already indicated it. You would use that. Calcium and vitamin D recommended to everybody, except for maybe people who have kidney stones. You don't want too much calcium to then kind of exacerbate that. Bisphosphonates no longer used for preventative therapy. What that means is to prevent osteoporosis or osteopenia from occurring. You do use it to prevent fractures. So if somebody is developing osteopenia or has developed osteoporosis, which those are separated just by the degree of bone loss, you're going to give bisphosphonates for the prevention of some kind of event from happening, like a fracture. Let's see. I want to make sure I think we'll talk more about bisphosphonates later, but bisphosphonates are going to be your main option for treatment of osteoporosis. There are once-a-day options, once-a-week options. There's an every 6-month injection or infusion you can get. So you can base your options for your patients on the cost of the medication and if the insurance will cover it, and which is going to help with compliance. So if I can remember, I'm going to take my Boniva or once a week every Monday, and I'm very good at that, then give them the once a week one. If they are good at once a month, give them the once a month one. If they forget and they need something every day to remind them, give them a daily option. Base it around that. They're all equally effective, and so we can just pick which one's going to help. You can continue reading on, and we'll see if it's later on in your slides, that there's a lot of talk about after 5 years of treating with bisphosphonates, of doing a holiday, because they think that long-term risk of bisphosphonates used just continuously forever actually increase the risk of microfractures in the bone. So small little fractures that are hard to see on x-rays but develop because you're increasing the bone formation so much that it may not be strong, well-built bone that you get after that during that first 5 years of therapy. You also have selective estrogen receptor modulators, so raloxifene. Um, they're also protective against breast cancer. Teriparatide is human parathyroid hormone. It's an injection. Um, I haven't seen a whole lot of patients on that. Um, and denosumab, which is your injectable or your infusion twice a year. It can be expensive, but insurance could cover it, especially if a patient's at risk of osteoporosis based on medications they're on. But it does have an increased risk of infection just because it is a monoclonal antibody. So you're going to want to rule out causes of low bone density first, and then measure bone mineral density. A 10% loss equals double the fracture risk. So you're going to use a DEXA scan or a dual energy X-ray absorptiometry. I am terrible at saying that one, but it's a DEXA scan. Everybody calls it DEXA. So you're going to do scans for women who are on long-term estrogen therapy, men and women with vertebral abnormalities, just for monitoring for osteoporosis. So you may start when someone is 40 or 50 and do it every 5 to 10 years. Patients on long-term glucocorticoid or thyroid therapy with diseases that have a risk of osteoporosis, and women older than 40 who have had a fracture in the past. Again, other considerations to take into account. Patient education, the role of diet, the role of other medications that may contribute, and the importance of continuing to take calcium and vitamin D regardless of treatment. And now vitamin D and calcium, they come in so many different options. You can take tablets, you can take one larger tablet, a couple of tablets a day. I think they've even got like chocolate candies now that have it. And, you do have to be careful on which type of calcium, whether it's calcium citrate or calcium carbonate they get, but the bottle will tell them how many to take. If they really have a question, send them to the pharmacist. They can go over which one has more elemental calcium, one is easier on the stomach, so, and then they'll want to make sure that they're taking enough, because those chocolate candies, they have them now in calcium. I think you have to take like 12 a day, which is not. People aren't going to complain about eating 12 chocolate candies a day, but they want to make sure they're taking enough to get in the amount they need. Keys for education. You must be upright for at least 30 minutes after taking a bisphosphonate, and you take it only with water. That can be a problem if the patient's also taking Synthroid. Or things that also have to be on an empty stomach. So what I would do is if they're on something that has to be on an empty stomach, try to go with the once a month option. So there's only one day that it's affected, and you could do one in the morning and one at bedtime. Maybe save the Synthroid. You can do the Synthroid at bedtime, or however it works in their schedule. Do the medication. Make sure they haven't eaten for so many hours. Take the medication. Sit upright for 30 minutes or an hour if it's Boniva, and then they can go to bed. So here are your uses for bisphosphonates. They inhibit osteoclast activity, so they prevent the breakdown of bones. It helps and then kind of plateaus after 2 to 3 years in significant GI and esophageal irritation, which is why you have to stay sitting up for so long afterwards. Here's your peak onset, again 3 to 6 weeks, which is quite a while, and it peaks in 3 to 6 months. It does not metabolize, and here's your information for any IV forms. Common adverse reactions. Mostly what you're going to see here is the GI stuff. Rare, but raises concern of femoral neck fractures, and then osteonecrosis is very, very rare, but you want to just tell people if they have any jaw pain to let you know. Because it's very, very rare that happens. Drug interactions to keep in mind, just ranitidine doubles alendronate bioavailability. Lab tests, when to do them, when to redo a DEXA scan. I would find a guideline that works for you and then just kind of follow it. It's been hard to get people to kind of make one concise recommendation. All the medical groups out there. These are very straightforward, separate for the separate classes to go in and kind of look at. Quickly, we're going to kind of knock out drugs used to treat inflammatory processes. These are used for all kinds of different medical disorders. So you've got corticosteroids, NSAIDs, and then aspirin and non-acetylated salicylates. So glucocorticoid actions, they inhibit immune and inflammatory responses. They can increase circulating erythrocytes, increase appetite, which causes a side effect for a lot of patients. You can have increase in glucose, serum glucose. Patients eat more. There's weight gain and the fat deposits in certain areas, in the face and the cervical areas. So you're going to see patients who have been on long-term steroids can have what they call moon face, where it's a very rounded face because of where the fat deposits there. And they can also have what's called a buffalo hump, which is a fat deposit in between the shoulder blades, which can be evident, especially if they're not a larger individual anyways. So it's something to keep in mind. Some more actions of glucocorticoids. We're talking about, and then we'll go to mineralocorticoid activities, which are all your steroids have some glucocorticoid and some mineralocorticoid activity. So ones like aldosterone are going to have mineralocorticoid activity, such as retaining sodium in water and excreting potassium. What we use commonly, prednisone, methylprednisolone, things like that, for oral steroid medications, have a lot of glucocorticoid action and not as much mineralocorticoid action. So you don't want to use them they're contraindicated if a patient has an active untreated infection. Use cautiously if a patient has uncontrolled hypertension or cardiovascular disorder, because it'll increase blood pressure, sodium and water retention, and excretion of potassium. And long-term use can increase the risk of osteoporosis. Patients with diabetes may have problems with glycemic control. They will have problems. There's no may about it. They will have problems with their glycemic control. So they may need to either, if it's a short-term 7 to 10 day regimen, they may need to kind of limit their carb intake a little bit better. And then if it's a long-term treatment, they may need to do like some kind of sliding scale insulin, where they can dose it based on what their blood sugar is at that point. You can also have atrophy and thinning of the skin. That's important when you have very thin skinned areas that would be going on, such as like eyelids or something like that. That's a very important one to keep in mind. And then muscle atrophy, truncal obesity, buffalo hump, and moon face. Remember those fat deposits. Let's see, more adverse drug reactions. Again, they're not clean, innocuous medications by any means, but they're commonly used. CNS. I want to point out the CNS side effects: the delirium, agitation, insomnia, mood swings, and severe depression. I actually know somebody who had who became catatonic from a steroid dose pack. They basically, it seemed like they kind of developed mania and slowly slipped into catatonia because of the psychiatric side effects of the steroids. Now, months later, they're fine, but it took a long time for those kind of to subside and treatment of those. But if a patient becomes hyperactive to the point of getting in the way of daily living activities, delirious, if they're having mood swings, they tell them they need to report them to you because you can put them on a different medication. Uses and adrenal insufficiency. Again, you can read through these for inflammation. If it's an infection that's also causing inflammation, they'll give these along with antibiotic. Immune suppression for any immune-related illnesses. RA. Again, it tells you which ones to commonly use and what your goal is. Principles of prescribing, read through those, pretty straightforward. How long to use them, what monitoring is necessary. Again, most of this is for long-term therapy, not for short-term. You don't need a CBC if you're going to write somebody a steroid for a respiratory infection. And watch for cataracts and glaucoma in long-term therapy. Administration. Drugs should not be abruptly discontinued. You're going to see a lot of that, a lot of steroid tapering packs. They already come prepackaged that way, and truthfully, your body doesn't. So when you have exogenous steroids or glucocorticoids, your body will stop making endogenous options. So if it's coming from outside of the body, your body's going to stop making it because it sees it as unnecessary. But that takes at least 14 days to occur. So if you're on a steroid for 3 or 4 days, you don't need to taper it. That's just a false. It's just a false common belief that's out there that they're on it for 4, 5, 7 days. We need to make sure it's a 7-day taper, and it's just not true. Now the availability of those dose packs makes it where most people, they'll just write for that taper dose pack and move on. That's fine. The only benefit to those is the ease of use. It's not because there's some clinically relevant reason why they're using that over saying just writing prednisone 20 milligrams daily times 7 days. They'll be fine without that taper, but you can use the packs if you'd like. So NSAIDs. NSAIDs inhibit COX-1 and COX-2 activity, thus inhibiting prostaglandin synthesis. So COX-1 is present in all tissues, especially the one we're thinking about is the GI tract, and COX-2 is an inducible enzyme that is synthesized in response to pain and inflammation. So all your NSAIDs work on COX-1 and COX-2, and then you have Celebrex or celecoxib, which only works on COX-2, which is supposed to be easier on the GI tract than your non-selective NSAIDs like ibuprofen or meloxicam or diclofenac or any of the others. Now, there's no evidence that Celebrex or celecoxib is less linked to cardiovascular events and side effects. It's only the GI that's really been proven. So if you have a patient who's had an ulcer before, it'd be good for them to get Celebrex. Other than that, it may or may not benefit them to pay more for the Celebrex as opposed to something over the counter or prescription like meloxicam or Mobic, which is a once a day NSAID at usually $4 at any pharmacy. So you can see the uses. Acetaminophen, they're going to lump in here also. We're all familiar with these. You can read through them. Again, most people link acetaminophen with liver issues and NSAIDs with kidney issues. It's not exactly as easy as that, but it's in your brain. Just link them together, and it'll make it easier to remember. Which ones to try to avoid. GI disturbances, we're not shocked by that. We've known that forever. Take your ibuprofen or your NSAID with some food, and it'll help prevent those. COX-2 inhibitors like celecoxib and all NSAIDs have a black box warning for cardiovascular risk. And again, that is because those cause sodium and water retention, and sodium and water retention cause cardiovascular events and hypertension, so which can lead to heart attack and stroke. So that's where they're linked. They don't have one that is less linked to this than the others. Again, here's where you would use certain NSAIDs or acetaminophen for certain issues. For the most part, they're all fairly mixable. You can pick which one. I really only see indomethacin used for gout, um, no other disorders, um, and I see naproxen used quite often just because it's a twice a day medication. Um, and then Sulindac. The only time I've seen Sulindac actually used is we use it for our patients on lithium because it's one of the few NSAIDs that doesn't have an interaction with lithium to cause lithium retention and possibly lithium toxicity. So most for your patients for gout, you're going to use indomethacin, and for just about everything else, they can use, go pick an NSAID based on how often a day they can take it, if they can be compliant, and the cost. So monitoring, again, much like steroids, more important if it's long-term therapy or we're using it continuously for for a long term. Aspirin and salicylates. Most people are familiar with obviously aspirin, whether it's the 81 milligram dose or the 325 milligram dose. 81 milligrams usually used for cardiovascular protection. Please don't call it a baby aspirin, because it kind of gives people the misdirect or the idea that aspirin can be given to babies, and we don't give aspirin or salicylates to patients at least under 12 years old. If not, at least wait till they're closer to 18, because it has a big risk of Reye's syndrome. So you can look that up. But we don't give aspirin to children. It is a small dose of aspirin, so that's where the baby aspirin name keeps coming from. But I really don't prefer that, because someone is going to hear that and remember, oh yeah, somebody told me it's baby aspirin, so I'm gonna give this to my baby, and have some adverse reactions from it. So side effects, not really surprising. GI irritation and ulcers and bleeding, first and foremost. Ototoxic at higher levels. Aspirin used by children and adolescents with influenza or chickenpox associated with development of Reye's syndrome. That doesn't have to be with influenza or chickenpox. It can just be at a young age. Avoid after surgery because of bleeding risk, and it's a pregnancy category D, so avoid it if possible. Here are the uses. Let's see. Pain, obviously. Give it for at an 81 milligram dose for secondary prevention of cardiovascular events. Myocardial prophylaxis. This even as something as simple as aspirin use for cardiovascular events is still, we're having trouble agreeing on the recommendations, and that's probably just because new information keeps coming out. For a long time, anybody who had a family member with a cardiovascular event should be on aspirin, and then that was changed to just patients who were diabetic and had other disease states, and then that was changed to now the current indication is secondary prevention of cardiovascular events. So someone who's already had one, had an event, should get prevention. I believe that is the current recommendation right now is the just secondary prevention of cardiovascular events. But it's constantly, it's about every year it's changing, it seems like. I added this note in here. I don't know why it has for monitoring a random salicylate level should be drawn 7 to 10 days after initiation of therapy. I've never heard of this. I've never seen this. I think somebody would get laughed out of the building if they tried to draw this, unless somebody thought they had, like, they trying to figure out if they had overdosed on aspirin. No one is ever going to get a salicylate level for a patient. Education on administration. Very short couple slides on muscle relaxants. These are pretty straightforward. When to use them, what they do, and then a few on opioids, which we are all familiar with. Your book goes much more in depth and better into we could do a whole class just on opioids. So there's better information from other sources on that. And with that, that is Module 8, very quickly gone through. If you have any questions, send me a message through Canvas.